Now we're going to go over the second perfusion PowerPoint. We're going to look at like heart failure, stuff like that. So these are just reviews. We know preload, that's the volume. And then afterload, what is afterload? That's the pressure. Now, what is MAP? What is the formula for MAP? 2 diastolic plus 1 systolic divided by 3. Now, what should the value be? Like, what's the normal range? Greater than 60 or 70 to 100. Cardiac output. What is cardiac output? Amount of blood pumped by the left ventricle each minute. The central, we know, is the heart. What is shock? Remember what shock is? Shock's when you're not getting enough oxygen and nutrients to the body, so it kind of dies on its own, stuff like that. And sepsis. What is sepsis? Infected blood, causes vasodilation, can't pump properly, leads to the shock, leads to multi-system organ failure. We know that. So over here we have central tissue perfusion. Okay, so on the right, would you say this is oxygenated or deoxygenated? I would say it's oxygenated. Why? Because once it goes into the lungs, it becomes oxygenated. Okay, so it goes. Starting here, vena cava to right atrium to right AV valve to right ventricle to pulmonary SL valve, pulmonary artery to arterioles, to arteries to arterioles to capillaries to venules to veins to pulmonary veins to the left atrium to the left AV valve, left ventricle, aortic SL valve to the aorta to the arteries of each organ to arterioles of each organ, and then back again. So we have heart disease major cause of morbidity in the U.S. What do you think are some ways we can prevent heart disease? Well, we can do it by having a healthy diet, exercising, moderating that alcohol. If you're a woman, 1 or less a day, male 2 or less a day, stop smoking, practice safe sex, get your immunizations, control your weight and blood pressure, and get your lipid screening tests. So heart failure, we know the heart is a pump, which means that it circulates blood. And can you tell me about the conduction system? Well, the conduction system, the SA node initiates, the SA node impulse initiates cardiac contractions, and baroreceptors in the aorta see that, okay, blood pressure's changed, so the SNS gets stimulated, it causes a heart rate, increase in heart rate, tachycardia, and increase in contractility. You also have the parasympathetic, the vagus nerve, which causes bradycardia, and so does the heart, stuff like that. So reviewing the nervous system, you got the autonomic nervous system. Sympathetic is the norepinephrine. You can have mydriosis, reduced saliva flow, increased stroke volume and heart rate, vasoconstriction, reduced peristalsis and secretion, getting glycogen converted to glucose, and inhibition of bladder contraction. Okay? So on the right, got the parasympathetics, rest and digest, ACH, and have meiosis, stimulated saliva flow, decreased heart rate, bronchoconstriction, peristalsis secretion, that'll be stimulated, in bladder contraction as well. So with the heart can't pump, we know cardiac output or stroke volume decreases, which means less blood is reaching the organs. And what are some of those symptoms you might see with that? Fatigue, lethargy, mild acidosis, decreased respiratory rate. Then you have like a backup, which leads to congestion develop. Output from the blood is less than inflow from the blood. What do you think the symptoms of left-sided heart failure would be? Dyspnea, orthopnea, cough, pink tinged, shortness of breath, hemoptysis, rales, lung problems. Obviously, if it's left, it's going back to the lungs. And then what do you think right-sided symptoms would be? Pendant edema in the feet, hepatomegaly, ascites, distended neck veins, and a headache, stuff like that. So congestive heart failure, the heart is unable to pump blood for metabolic needs. It could be acute or chronic. It could be a heart problem involving the heart walls or conduction, or it could be a valve deficit. So with high demand by hypertension, that increases afterload, which increases heart rate, which increases demand, or lung disease, stuff like that. Not too bad. So what happens in heart failure? What do you think? The big thing. Heart can't pump enough blood to the rest of the body. So ejection fraction, that's a measurement of what? How well the heart is pumping, and what is ejection fraction used to classify heart failure? So what's a normal heart failure ejection fraction range? 50 to 70. Make sure it's greater than 50. So tell me about reduced blood flow. So you're going to have reduced systemic and renal blood flow, which causes renin and aldosterone to be secreted. So that causes vasoconstriction or increased afterload, and increased bladder volume, which is increased preload, which adds to the heart's workload. Then the SNS response causes increased heart rate and peripheral resistance. This decreases efficiency in filling, which increases work for the heart. This causes the heart chambers to dilate, and you have cardiomegaly, causing the walls to thicken and stuff like that. Okay, so what do you think diastolic heart failure is? Heart failure with the preserved ejection fraction. What do you think some of the path of heart failure would be? Fluid back up in the lungs, fluid back up into the abdomen, legs, and feet. Maybe the left ventricle can't contract vigorously, have like a pumping problem, or the left ventricle can't relax or fill fully, which is like a filling problem. So what do you think are some of the etiology or causes of heart failure? Maybe coronary artery disease, which is damage or disease in the heart's major blood vessels, which is like the usual cause is the buildup of plaque. This causes coronary arteries to narrow, limiting blood flow to the heart. There's really can be a range of symptoms to no symptoms, chest pain to a heart attack, stuff like that. It can be caused by an MI. This is a blockage of blood flow to the heart. It is a medical emergency. A heart attack usually occurs when a blood clot blocks blood flow to the heart. Without blood, tissues lose oxygen and die. You'll have like chest tightness, pain in the back, neck, arms, chest, as well as fatigue, lightheadedness, abnormal heartbeat, and anxiety. Women usually have no symptoms, which is kind of crazy. This can also be caused by hypertension. Basically, it's a condition in which the force of the blood against the artery walls is too high. That's usually defined by a BP of 140 over 90, and severe if it's over 180, if it's 180 over 120. These can also be caused by faulty or damaged heart valves. So some of the heart valve problems could be like regurgitation, stenosis, or atresia. Regurgitation is backflow. It occurs if the valve doesn't close tightly. Blood leaks back into the chambers rather than flowing forward through the heart or into an artery. Stenosis, that occurs if the flaps of the valve thicken, stiffen, or fuse together. This prevents the heart valve from fully opening, which causes not enough blood to flow through the valve, which is kind of crazy. And then atresia, that occurs if a heart valve lacks an opening for blood to pass through. Cardiomyopathy can also cause heart failure, and that is an acquired or hereditary disease of the heart muscle. It makes it hard for the heart to deliver blood to the body and can lead to heart failure. They may have breathlessness, swollen legs and feet, and a bloated belly. Myocarditis may also cause heart failure. That's inflammation of the middle layer of the heart wall. It's usually caused by a viral infection. A severe case can weaken the heart, which can lead to heart failure, abnormal heartbeat, and sudden death. We experience like chest pain, normal heartbeat, and shortness of breath. And then like congenital birth defects and arrhythmias can cause this too. So like heart failure can cause you to be at risk for having a MI, but if you have an MI, this can also cause heart failure. So you can also assess risk factors, so like demographic data, family history, respiratory history, cardiovascular history, environmental history, and lifestyle. And then again, we talked about this for the assessments. What are we going to assess when it comes to central perfusion? It'll be that heart rate, the blood pressure, the labs, the BNP, and the urinary output. What are you going to assess when it comes to cerebral perfusion? The orientation, the bilateral movements, sensation, speech, carotid pulses, and what are we going to assess when it comes to peripheral tissues? Is the skin warm? Is it appropriate color? Is it dry? Are there pulses? Are they regular rhythm? Is the cap refill less than 2? Stuff like that. So on the physical exam, we're going to see, are they anxious? We're going to check their height and weight, specifically for meds. We're going to inspect their skin, their mucous membranes and edema, palpate pulses, skin temperature and edema, oscillate heart sounds, blood pressure, and lungs. If they have any pain, that's a common heart attack symptom. And if they have fatigue, subjective, tired and lack of endurance, and dyspnea, like shortness of breath, which is a sign of hypoxia, can also cause that anxiety. So, an ECG, we know that is a non-invasive conductive activity of the heart. Some ways we can assess for murmurs. How do you think that can be? Auscultation and echo. Why do we do the exercise stress test for the bike? Well, because we can. Why would we do a chest x-ray? See the size and shape of the heart and if there's any pulmonary congestion. Why do we do nuclear imaging? Assess the size of infarct, see if there's any myocardial perfusion. Check the ventricle function and tissue mass. Be careful because of the dye, because allergies and kidney function. Why would we do a CAT scan? Going to assess cardiac ischemia at rest. Why would we do cardiac cath? We're going to assess the inside of the heart, and when is troponin released? Cardiac muscle is damaged. So some general treatment measures. What do you think some of these could be? Obviously, diet modification, specifically reducing sodium in water, exercising, smoking, and drug therapy, stuff like that. So These are the meds. So vasodilators, why do we use those? To reduce the workload and reduce blood pressure. Why do we use beta blockers? To treat hypertension and dysrhythmias, prevent sympathetic nervous system from increasing heart rate. Why do we use calcium channel blockers? Decrease cardiac contractility. Why do we use digoxin? Treat heart failure, dysrhythmias, and that can slow conduction of impulses and heart rate. Why would we use ACE inhibitors? These are the preferred treatment in hypertension and heart failure. They block conversion of angiotensin 1 to 2, stimulate from renin in the kidneys, and reduces peripheral resistance, which decreases preload and afterload. And why would we use diuretics? Remove sodium in water. That increases urinary output, and reduces blood volume and edema. So, heart failure side effects. You got left-sided and right-sided. We talked about them, but we'll go over them a little bit. So you got left-sided would be like paroxysmal nocturnal dyspnea, elevated pulmonary capillary wedge pressure, maybe some pulmonary congestion, a little restless, kind of confused, orthopnea, tachycardia, exertional dyspnea, fatigue, and cyanosis. And on the right side, you have like fatigue, increased peripheral venous pressure, ascites, enlarged liver and spleen, maybe secondary to chronic pulmonary problems, extended jugular veins, anorexia and complaints of GI distress, weight gain, and dependent edema. So, chronic or acute heart failure. If you're going to have a chronic heart failure, you're going to have shortness of breath or dyspnea, fatigue and weakness, going to have edema, rapid heart rate, reduced ability to exercise. You're going to have a pink, blood-tinged phlegm, cough, and increased need to urinate. What do you think you'd have if you have acute heart failure? Ascites, rapid weight gain from fluid retention, lack of appetite and nausea, decreased LOC, severe shortness of breath and coughing up pink foamy mucus, and chest pain if it's caused by a heart attack. So what do you think of the common symptoms of heart failure might be? Shortness of breath, having trouble breathing and lying down, so orthopnea, edema, and feeling tired and weak. So what do you think are some ways to treat heart failure? Take meds, reduce sodium in diet, drink less liquids, devices that remove excess salt and water, heart transplant, physical activity, stuff like that. So how are we going to monitor and support adequate ventilation? We're going to record the I&O, limit the fluids and sodium per order, provide small frequent meals, and auscultate for S3 and S4, monitor and control that bleeding, and then manage that anxiety. How do we maintain adequate ventilation and perfusion? Positioning, semi-Fowler to high Fowlers, turning frequently, administer oxygen as prescribed, get bloods and meds order, and monitor O2 sats, and schedule nursing care to provide rest and minimize fatigue, stuff like that. We also have to promote the circulation, teach to avoid sitting with legs crossed, encourage and support early and frequent ambulation, provide range of motion exercise, stuff like that. So what do you think we'll teach the patient when it comes to like heart failure, how to make sure it doesn't ever happen again and to minimize things? Obviously stop smoking, change their lifestyle, get the exercise, medication, stuff like that. So what would you say CDC's biggest heart failure risk factors are? CAD, diabetes, hypertension, obesity, and valvular heart disease. So what do you think some of the modifiable risk factors are? Smoking, eating diets high in fat, cholesterol, and sodium, being sedentary, and excessive alcohol. But again, we can't change what? Age, genetics, race, and family history.